Hey, good afternoon, everyone, and thanks to coming to our monthly Lunch and Learn. Today's topic is neurocognitive disorders with a focus on Alzheimer's disease and documentation for an accurate and complete risk adjustment. So just a little about me. My name is Jolene Hanzik, and I'm a nurse practitioner and a certified risk adjustment coder. My background is mainly emergency medicine and primary care, and I divide my time between Vatica and clinical practice. And this presentation is a collaboration with Kristen Curtis, a registered nurse and a certified risk adjustment coder. And so here's the game plan. We'll briefly review some basics about neurocognitive disorders. You know this well, but next we'll look at documentation related to coding them along with a case study. And then we'll walk through some documentation tips and wrap it up with a live question and answer session. So drop your questions in the chat at any time. So to get started, this is why we care about coding as providers. It's a busy slide, but in a nutshell. ICD-10 codes transforms our clinical language into standardized coded data. A few of the many things this data is used for are medical research, quality reporting, public health data, and determining medical necessity. They're also used to create a risk adjustment score that reflects the complexity of a patient's health condition, and this is used to determine the resources needed to care for that patient. If our documentation isn't accurate and complete, then we're going to risk overestimating or underestimating the resources needed. Risk adjustment, it relies entirely on our accurate documentation as providers to drive this entire process. However, we weren't taught coding in school, and clinical documentation doesn't always align with coding practices, so we're here to help bridge that gap between what we see in the real world and apply coding principles to our clinical documentation. So before we get into documentation, let's take a look, our moment to review some neurocognitive disorders and focus on Alzheimer's disease, or AD, since it's the most common, and there's been some significant developments. This is just meant to set the stage and help strengthen clinical documentation and align with coding practice. So you already know the basics, but it's worth revisiting that the most influential and widely recognized guidance comes from the National Institute on Aging and Alzheimer's Association, or NIAAA. In 2024, the NIAAA work group released updated clinical practice guidelines for diagnosing Alzheimer's disease and related disorders. These updates give clinicians in all settings a framework for evaluating patients with symptoms that may indicate Alzheimer's disease or related disorders. Both were published in 2024, and they reflect some major advances in Alzheimer's disease, particularly how it's diagnosed, staged, and managed. And here's two key publications for your reference. And here's some of the major developments that prompted the NIAAA to update the diagnostic and staging criteria for Alzheimer's in 2024. So for the first time, we have treatments that directly target pathology in Alzheimer's disease. The FDA approved lecanemab and donanemab, and these are monoclonal antibodies that target amyloid plaques in the brain. They're only approved in those with mild cognitive impairment or mild dementia with confirmed amyloid plaques. So this requires timely and accurate diagnosis of AD. Another significant development is the emergence of blood-based biomarkers. This access has the potential to transform clinical practice, potentially making biologic screening of Alzheimer's disease pathology available outside of other specialty centers. We're in a transition phase right now where blood-based biomarkers are being integrated with the traditional CSF and PET scan biomarkers. And these new therapies and biomarkers, they make it especially important to have alignment among clinicians about the diagnosis and staging of AD. So the standard for defining disease is based on biology rather than symptoms. However, Alzheimer's has primarily been a clinical diagnosis of exclusion based on a history of insidious onset, a progressive course of cognitive decline, and documentation of cognitive impairment in one or more domains. The biologic-based diagnosis and staging system is now moving beyond just the research environment and into clinical care as well. It's not operational at all centers at this time, and access can vary widely depending on resources and setting, so we do still clinically stage as needed. There's several different biomarkers available in three main classes. There's imaging, cerebral spinal fluid, and plasma biomarkers. And the NIA-AA, they define core 1 biomarkers as markers that change early in disease, and these include amyloid PET scans, CSF biomarkers, and plasma biomarkers. The core 2 biomarkers, they change later in the disease and they can provide more prognostic information. And these include certain CSF and plasma biomarkers of tau and tau PET imaging. These biomarkers, they're used to stage the disease independent of clinical symptoms. And of course, each one has advantages and disadvantages, like different in sensitivity, specificity, cost, and availability. So as always, your clinical judgment is key. And I have some more information about the biomarkers here for your reference, but we're not going to cover each due to time. So understanding the fundamentals of DSM-5-TR categories of neurocognitive disorders is helpful in documentation and coding. It provides a broader framework and scope that includes all neurocognitive disorders. Well, the NIA-AA is designed specifically for Alzheimer's disease and related disorders, and it includes asymptomatic and symptomatic stages. These two systems are complementary and they share a goal in diagnosing cognitive decline. So I'm going to pair the two for a more comprehensive picture instead of just limiting to Alzheimer's. And one of the things that makes it challenging is they use different terminology. So as we go through, I'll connect the two when it's helpful for documentation. So DSM-5-TR, they recognize three neurocognitive disorders, or NCDs. One is delirium, which is an acute disorder of cognition and attention, so we're not going to go into this. But then we have mild neurocognitive disorder, which we usually refer to as mild cognitive impairment, and a major neurocognitive disorder, which includes dementia. The NCDs are unique for DSM-5 categories because they're syndromes and the underlying disease can usually be determined. The mild and major NCDs, they have subtypes, which are the underlying cause of the NCD. The subtypes include what the NIA-AA refers to as Alzheimer's disease and related disorders. So Alzheimer's, frontotemporal degeneration, Lewy body's disease, vascular disease, along with other disorders. And here's the full list just for your reference. So what is mild cognitive impairment? According to NIA-AA, it means a person is experiencing cognitive decline. This may be based on concern by the individual or someone that knows the person. And there must be objective evidence of impairment in one or more cognitive domain, usually through cognitive testing like a MOCA or a neuropsych eval. This cognitive decline is not bad enough to affect their day-to-day functioning. They say they're doing everything they used to, but for example, they may have to write things down when they go to the grocery store. The person can still handle daily tasks like driving, finances, and shopping, so they don't meet the criteria for dementia. So now let's define NIA-AA criteria for dementia, which is included in DSM-5 major neurocognitive disorder. So dementia is diagnosed when there's significant cognitive impairment that limits function. It interferes with the ability to function at work or usual activities. It's a decline from previous levels of functioning, and it's not explained by delirium or a major psychiatric disorder. Cognitive impairment is detected and diagnosed through history from the patient or someone that knows them and an objective cognitive assessment. In neuropsych testing, it should be performed when the routine history and cognitive assessment don't provide a confident diagnosis. Cognitive or behavioral impairment, it must involve a minimum of 2 domains. And I have the domains here for your reference. One of the most frequent presentations of Alzheimer's is memory impairment. So this framework for the evaluation of patients with cognitive impairment is from the 2024 NIA-AA publication, and it represents the 7 core elements for patients that may be exhibiting signs and symptoms of cognitive impairment due to Alzheimer's disease or related disorders. So very briefly, Core 1 is establishing shared goals. Core 2 is your HPI. 3 is the review of symptoms. And Core 5 is a focus exam and a mental status exam with a validated instrument. And two widely used instruments are the MOCA and the MiniCog. In most cases, you're going to get a cognitive lab panel. It's usually a CBC, Chem7, TSH, B12, homocysteine, ESR, and CRP, as well as a brain MRI or a head CT if MRI is not available or contraindicated. We search very carefully to find a reversible cause, although they're less common. It could be a low thyroid, low B12, strokes, or a benign brain tumor. Core 6 is the diagnostic step in formulation, where you use all the information you gathered and formulate a diagnosis using 3 steps. 1 is to delineate the cognitive functional status. Next, characterize the cognitive behavioral syndrome. And third is to determine the likely cause. And this is where we're going to zoom in. I'm going to pair this up with DSM-5 steps to ultimately lead to an accurate ICD-10 code. Core 6, Step 1 is to delineate cognitive functional status or level of impairment into one of 4 categories: cognitively unimpaired, subjective cognitive decline, mild cognitive impairment, or dementia, and then specify if the dementia is mild, moderate, severe, or terminal. This determination has important implications for the evaluation process and care planning. So the first 2 aren't diagnoses. For cognitively unimpaired, it means the person has no cognitive complaints and they don't have anything wrong with their memory tested. So it may be appropriate to use something like an encounter for screening for cognitive decline. Now, many people experience subjective cognitive decline, where they feel like their memory is worse, but testing shows it's normal for their age. And in that case, it doesn't meet criteria for a cognitive impairment. And when we get some mild cognitive impairment, there's a few choices. You would use G3184 for MCI where the cause is not known, FO670 for MCI when the cause is known and there's not any behavioral disturbances, and FO671 for MCI with a known cause and the patient has behavioral disturbance. And traditionally, we really haven't used a mild neurocognitive disorder due to Alzheimer's, because Alzheimer's, it's typically diagnosed based on clinical findings that are caught when there's already a noticeable decline in independence, and then that defines dementia. However, with advances in the use of biomarkers, AD is now seen on a clinical continuum, and it can start at the preclinical phase when an individual is asymptomatic. And one reason this distinction is important is because current disease-modifying therapies are only approved for those with MCI or mild dementia due to Alzheimer's. So far, it's been pretty straightforward, but when we get to dementia, they ask a lot. Severity needs to be specified as mild, moderate, or severe. There's many ways to gauge this, so use what your clinical judgment and what you're comfortable with. DSM-5 recommends the following. So mild when there's difficulties with instrumental ADLs like housework or managing money. Moderate when there's difficulties with basic ADLs like eating and getting dressed. And severe is fully dependent. And when it comes to ICD-10, mild, moderate, and severe requires your clinical judgment and is assigned based on your documentation. If the severity is not documented, then a code for unspecified severity is used. And one other note, there's 3 main ICD-10 categories for dementia. You have vascular dementia as one type, dementia in disease elsewhere classified is when the disease causing the dementia is known, and unspecified is when the specific cause is not documented or known. So the NIA-AA Core 6, Step 2, is to characterize cognitive behavioral syndromes like memory or language. This helps narrow the differential diagnosis, determine the next step in the diagnostic approach, and it heavily impacts symptom management and care planning. So DSM-5, it instructs to determine if the disorder is without behavioral disturbance or with behavioral disturbance. And if there's behavioral disturbance, ICD-10 aligns and has a code for 5 broad categories: agitation, other behavioral disturbance, psychotic disorders, mood disorders, and anxiety. So here's some examples of symptoms that fall into the different categories for your reference. And another point to behavioral disturbance. The ICD-10 dementia codes use the word with, dementia with behavioral disturbance. This means a causal relationship between the dementia and the behavioral disturbance is assumed. By this guideline, if the patient has dementia and one of the documented behavioral disturbance, then they're automatically linked unless you specifically document that they're not related. So clinically, we understand a patient may have anxiety or depression long before the dementia, but dementia has certainly made it worse. And so this is similar to combination codes like diabetes with CKD. So for your reference, this coding clinic explains the presumed relationship between dementia and depression is coded as dementia with mood disturbance unless you document that it's related to another cause or that it's unrelated to dementia. Here's another similar coding clinic that advises if a patient has dementia, anxiety, and depression, assign codes for dementia with anxiety and dementia with mood disturbance unless documentation states otherwise. So to summarize dementia codes, there's 3 main categories of dementia in ICD-10. Vascular dementia is FO1, dementia and other disease classified elsewhere is FO2, and unspecified dementia is FO3. Each category can be further specified by severity of mild, moderate, or severe, and the presence or absence of behavioral disturbances like agitation, psychotic disturbance, mood disturbance, and anxiety. And this is what it looks like for vascular dementia. This category is unique in that it's both the cause, dementia due to vascular disease in the brain, and it covers the manifestation of dementia. So next is unspecified dementia, which is used when the specific cause isn't documented or known. And the last ICD-10 dementia category is dementia and disease classified elsewhere. And this is used when the disease causing the dementia is known, so it requires a second code to identify the cause. And that brings us to the final NIA-AA. Step 3 of Core 6, diagnostic steps and formulation, is to determine the likely cause or etiological diagnosis. And this is where you narrow the differential diagnosis of the brain disease that is the cause of the patient's cognitive behavioral syndrome. So DSM-5, it gives a list of known causes of dementia. It includes Alzheimer's disease and the main related disorders, so frontotemporal degeneration, Lewy body's disease, and vascular dementia, as well as several other disorders. It also lists other specified and unspecified causes, which essentially makes it an unlimited list. So the cause is what you've determined it to be. It doesn't have to be picked from the list. These are just common causes. And when it comes to ICD-10, dementia and other disease classified elsewhere contains the word other. And whenever you see the word other in a code, you have to tell us what the other is and code for it. So 2 codes are required. 1 code for the functional status or manifestation, and 1 etiology code. So one last coding clinic guideline that's unique to Alzheimer's disease. This reference states that dementia is an inherent part of Alzheimer's disease, and therefore dementia does not need to be separately documented by the provider for it to be coded. Since the original coding clinic codes for mild cognitive disorder due to a known cause have been added, this means that in addition to the code for Alzheimer's disease, a second manifestation code is required to fully capture the condition, and the key difference here is that it's required. So like we previously discussed, for Alzheimer's disease and related disorders, you should describe the cognitive functional status with a manifestation code. The difference with Alzheimer's disease is if the provider documentation does not describe the manifestation, then coders are directed to assign dementia and disease classified elsewhere or a mild neurocognitive disorder due to a known cause. So my best advice to you is just be sure you document your patient's cognitive or functional status as cognitively unimpaired, subjective cognitive decline, mild cognitive impairment, or dementia to accurately capture their condition. So let's put everything together in a case study. This is a 72-year-old woman that reports increased forgetfulness. She's accompanied by her family that reports she's had a gradual, insidious decline in memory over the past year. She repeats questions, misplaces items, and has occasional difficulty finding words. She's becoming less independent as she needs help getting dressed and with finances. There's no hallucinations or motor symptoms, no acute confusion, and no recent illness. Her MoCA score is 17 out of 30, so we have objective evidence of impairment. MRI shows hippocampal atrophy without evidence of a stroke. Lab studies are unremarkable, and amyloid PET is positive. So the first step is to describe her cognitive functional status. This has symptoms that interfere with her usual activities and a decline in her previous level of functioning. She's no longer fully independent. Her evaluation ruled out other conditions like a stroke or a psychiatric illness. Her MoCA score is objective evidence of cognitive decline, and she also has impairment in at least 3 cognitive domains. So based on this information, we diagnose dementia. The next step is to determine the severity as mild, moderate, or severe. So based on a MoCA of 17, and since she's developed difficulties getting dressed, which is an ADL, we determined that the dementia is moderate. There's no behavioral symptoms like agitation, mood disorder, or anxiety, so the dementia is without behavioral disturbance. And finally, we determined the cause of the dementia is Alzheimer's disease with the help of a positive amyloid PET from her neuropsych consult. The first diagnosis, G30.9, Alzheimer's disease unspecified, is less specific, and there's no code to describe the manifestation. A more specific diagnosis is G30.1 for Alzheimer's disease with late onset, and FO2B0, dementia and other disease classified elsewhere, moderate, without behavioral disturbance. So to summarize, here's a few main points to keep in mind for documentation. For any middle-aged or older patient who self-reports or someone who knows them well reports concern about cognitive or functional decline, document a clinical history and include information from a reliable informant if one is available. Document cognitive and behavioral symptoms, include ADLs, IADLs, mood, any other neuropsych symptoms, and risk factors. Document your mental status exam, dementia-focused neuro exam, and include findings from a validated tool if you have it. Document results from labs and neuroimaging. First-line tests, they often include the cognitive lab panel and an MRI, and document biomarkers or PET imaging if they're available. Document the cognitive functional status as cognitively unimpaired, subjective cognitive decline, mild cognitive impairment, or mild, moderate, or severe dementia. And then next, characterize the cognitive behavioral syndrome. Describe any deficits in cognitive domains, any behavioral disturbances, and then determine and code the cause of the neurocognitive disorder. Document the treatment plan and include any medicines, diagnostic orders, and referrals. Select the most specific code for cognitive functional status. Combine the relevant behavioral disturbances and code the cause of the disorder if known. So that's neurocognitive disorders. It's a lot of information. You're going to get a copy of the slides in your email next week. You can also watch a replay of this session along with all of our other Lunch and Learn presentations anytime at our website at vaticahealth.com. We'll also offer 3 live 1-hour sessions next year that are approved for Category 1 CME, so keep an eye out for those if you'd like to join us for a deeper dive. And now we'll open it up for a live question and answer session. So if you have questions, drop them in the chat. And if something comes to mind later, please don't hesitate to reach out to us by email at providereducationsupport@vaticahealth.com. We truly appreciate the opportunities to support our providers, and we want to thank you for joining us today.